Good afternoon, everyone joining us. We're just going to give it a couple of moments for everybody to be able to log on, and then we'll get going for today's session. Right, what time we got? Okay, as you're all logging on, good afternoon. Welcome to our fourth Community Oncology webinar. I'm Charlotte Stevenson and I'm a Business Development Manager at Cardiff University, and it's my role to support these fantastic webinars. A few bits of housekeeping before we get going. We've got the chat function available at the bottom if you want to chat to any of the team, you've got any sound issues or anything like that. We've also got the Q&A there. Please pop any questions you've got about the content and we'll try and make sure our fantastic speakers answer all the questions you have at the end. And we're all working in different locations this morning, so please bear with us. I know one of us has got builders here, any tech problems, any interruptions from animals. And in order to keep this activity going free of charge, we really need any feedback that you can provide us. So at the end, there's a QR code, and I'll also be sending out a link to our feedback forms. And I would be really appreciative if you could take a few moments to fill those in. That's enough from me. I'm going to hand over to Fiona.
Great, thank you very much, Charlotte, and welcome everybody. We can't believe that we've got to the fourth of the webinar series. It's a real delight to be able to welcome you all from wherever you are, wherever you're working. And as some of you will know, this has arisen from a short course that we did face-to-face 2 years ago. We had it all planned for last year, and then coronavirus came and stole our thunder. But so we're delighted to be able to do at least something this year. But you're a wonderful big group from all over, and just to help us to kind of understand how the group's going to work today, we've got a poll just about what your role is and where you come from. So Charlotte, I wonder whether you can pop that up. So the first question is, what's your main role? So where are you based? Any questions as we go through are all considered, so please use the question and answer function, please use the chat function. We will be monitoring that as we go along. That's lovely. So predominantly in general practice at the moment, that's fantastic, but a mix of disciplines, lovely, that's great. And the next one is just actually, where are you joining us from? We have had people from overseas. Forgive me if you're new to us and I've said somewhere else here. That's just because there's so many places you could be from. That we thought somewhere else was just the best way to capture it. But I think the main thing for the session today is, if you are joining us from outside Wales, think about these issues where you are, and if you're not quite sure how services work where you are, as a result of today, maybe just go and ask somebody, see where the diagnostic pathways are. Anyway, that's fantastic. At the moment, predominantly from Wales, but some from England. So thank you very much. Thank you for joining us. We really hope you enjoy the webinar, and we would really value your feedback at the end. Thanks, Charlotte. I think we can take the polls down, and then over to Elise.
Yeah, good afternoon. Thanks, Fiona. Lovely to see you all and have you all with us today. So today is an interesting one, really. We're talking about malignancy of unknown origin, cancer of unknown primary, which I'm sure as GPs in primary care and in other roles we've encountered somewhere where you get a scan result which shows something disseminated but no obvious primary, for example. And I guess it's just trying to support primary care and other specialities about how we support the patient to the best, and how we can help diagnose them earlier and support them through the cancer experience that they have. So we've got three speakers who predominantly work with cancer of unknown primary or rapid diagnosis centres, and then Mick Button, who you've met before, who's doing a little bit on radiotherapy at the end. So the first speaker this afternoon is Dr. Elaine Hampson, who is a GP in Betsy, Cadwallader, and she's going to talk to us about acute oncology services up in North Wales, but this is applicable to all Wales and hopefully where you are too. Elaine.
Right, thank you, Elise. Thank you. So today I was actually going to sort of focus in on acute oncology, but malignancy of unknown primary service is usually encompassed within the acute oncology service. So, what is acute oncology? Now, before I applied for the post as an acute oncology Macmillan GP facilitator, I wasn't really quite sure Why does acute oncology actually matter to us in primary care, and why do we need to know about it? We also want to talk about where do I go to find out more. And lastly, I'll talk briefly about performance status, which is, as I've discovered, is something that's important in decision making for patients with cancer, but isn't something we often know a lot about as a GP. So what is acute oncology? Put simply, it's a service for people presenting with oncological emergencies. These might be due to side effects of their cancer treatment or due to complications of the cancer itself. And including progression of the disease and metastatic disease. And as I've just said, it also includes service for patients with malignancy of unknown origin. And patients with malignancy of unknown origin are patients that have been found to have a malignancy, and as Elise says, maybe they've had a scan which has identified metastatic disease, but there's no primary site found. The service involves assessing the patient and their wishes and to decide if and what further investigations are undertaken. So, isn't acute oncology a specialist field? Some of it very much is, particularly for patients who are currently receiving SACT or systemic anti-cancer therapy, or better known as chemo or immunotherapy. In primary care, we don't need to know a huge amount about these treatments, but we may become involved when a patients are experiencing difficulties. So receiving good quality information from secondary care is really important. To enable us to be better informed in primary care, improving communication between primary and secondary care has been an important part of my role as a Macmillan GP, and still is. Some of this is simply been querying the use of abbreviations and jargon while attending MDT meetings, so that the information we receive in primary care is much more understandable. Such as, it wasn't until I started attending the MDT meetings I understood that BSC stood for Best Supportive Care. There are a lot of potential side effects for those receiving treatments, but this is beyond the scope of today's presentation. And complications of cancer due to the recurrence of the cancer or due to metastatic disease often occurs years after treatment, and primary care is likely to be the first port of call. The risk of death when you've had an acute oncology emergency admission is quite high. 20% of patients attending the Belinda assessment unit died within 60 days. So admission is a poor prognostic indicator, and it should be a flag to start anticipatory care discussions, if not done so already. Also, 25% of acute oncology admissions are with cancer progression. So, and we go on to the patients who are receiving systemic anti-cancer therapy should receive information about their treatment they're having and how to access the triage line for advice if they have any concerns. Many patients will do this and we won't actually know about it in primary care, but some patients prefer to contact primary care first. This can be for a number of reasons. When I was a GP in Holyhead, our patients didn't want to travel 20 miles to the hospital if they could avoid it. And some patients just simply don't want to bother their hospital as they perceive them as being very busy. And some patients will have contacted the triage line and been advised to contact their own GP. There's a patient I saw recently being given advice to contact the GP as the triage nurse was concerned he might have shingles, and obviously if he did, she didn't want him on the oncology unit with other people that are immunosuppressed. And district nurses are often one of the points of contact for patients, as they might be actually seeing them to manage part of their treatment and help them with care. So, and some patients simply want to discuss the pros and cons of treatment with someone they know in primary care. So again, it's really important we've had good information. Currently being implemented are treatment summaries, which is to be sent at the end of the course of treatment, and working with secondary care colleagues to improve the information being sent to primary care at the start of treatment and along the route too. So you don't have to spend ages going through various letters trying to find out actually what is the diagnosis and majorly what is the intent of treatment. And this can really help with the conversations that we have with patients too, and also a better understanding of the complications of treatment. So acute oncology is not an area in which we get a lot of training, if any. It's difficult to know what we can do ourselves and what we should be referring on. We don't want our patients waiting around in the emergency department if it can be avoided. However, knowing what is an emergency is also important, such as could this be neutropenic sepsis. Also, it is a help knowing how to access advice and if needed, how to arrange an admission. A lot of patients think because they're a cancer patient, we can always arrange admission direct to the cancer unit, but as you'll be aware, this is very often not possible. However, being able to alert the acute oncology nurse to the patient coming in means that she can be aware of the admission and can get involved at an earlier stage. So complications of cancer. We certainly need to be alert to the potential of recurrence and metastatic disease, which is why it is important that cancers are always coded as significant active problems in patients' records. So we keep them in mind when seeing a patient with a history of cancer even years later. One patient that always sticks in my mind that I saw a few years ago came in to see me, delightedly telling me that she'd been discharged by the breast surgeon as she was now 5 years after having treatment for her breast cancer. However, she got to the point of the consultation, which was if she was feeling nauseous. Unfortunately, on an abdominal examination, I found she had a very large liver, and she was consequently diagnosed with liver metastases. And I'm sure many of you got similar tales to tell. So being given information about the risk of recurrence or metastatic disease and the potential symptoms and signs to look for is something I think that could be improved, both in information to the patient themselves and also to primary care. So acute oncology guidance for primary care. There is places where you can go for further information. So Valindra offer a free app. So you just search for acute oncology support, which can take you through different symptoms and what the suggestions are to do. And UCONS, which is the UK Oncology Nursing Society, have a primary care risk assessment tool, which is available on their website. And also most triage lines are available for primary care to ring for advice too, if the patient hasn't already done so or they're reluctant to do so, as I sometimes find patients are. Right. So then on to malignancy of unknown origin or cancer of unknown primary, which I've already discussed. So by its nature, patients are usually presenting with very advanced disease, and it's often progressing very quickly, and therefore poses two particular challenges. The first is that patients generally present with non-specific symptoms, which, although can trigger a gut feeling of possible cancer, are often not sufficient for referral through a site-specific cancer referral. This is where rapid diagnostic clinics, which Heather's going to talk about later, can be really helpful. And the second is how far is it sensible to continue with investigating the treatment? Consideration is needed of what the patient's own wishes are, and would the patient be fit enough for any potential palliative systemic treatments if a definitive diagnosis was made? Okay, as you can see, the statistics are not great for patients with malignancy of unknown origin. So I've tagged performance status onto the end. It's not something I've been used to using in general practice, but found it's really important to the oncology team in assessing the patients' changes to how they've been, and also taking decisions as to whether a patient will cope with investigations and treatments. This has been even more important since patients are being assessed remotely much more. There are other tools that you can use, but the one generally used is the ECOG, or European Cooperative Oncology Group 1. Generally, to be fit enough to cope with chemotherapy, patients need to score 0, 1 or 2, and very occasionally 3. So including a performance status when referring or in your assessment when asking for advice can be really helpful to our secondary care colleagues. Okay, so just to summarise what we've covered. Acute oncology covers complications from cancer and its treatment. It includes patients with malignancy of unknown origin, access to advice about side effects of cancer treatment, the importance of coding cancer and cancer treatments in patients' record for future reference, acute oncology admission is a flag for anticipatory care discussions, and also about performance status. So thank you very much.
Thanks ever so much, Elaine. That's really useful. I think the performance status stuff is something I've been aware of as well with the work in Valindra that I do for Macmillan. And so I'm familiar with it, and it is useful to include on referrals actually, and very, very helpful, for the palliative care team as well to know what we're describing. We previously used sort of adjectives, haven't you, like very well man or something, but actually if you can give it a number, it is useful. Elaine, I know you're busy in surgery this afternoon, but any questions that people want to pop in the chat, I'm happy to pass to Elaine if she's not with us for the very end of the call, or we can try and answer through the chat function and the Q&A function as well. I'm aware there's a lot to get through. So the next speaker is Sonali Dasgupta, who's one of my Velindre colleagues. She's a consultant medical oncologist at Velindre Cancer Centre in South Wales. Sonali. Can you hear me, Sonali? You need to come off mute. Yeah, lovely.
Yeah. Sorry, I've just unmuted myself there. Thank you very much for that introduction, Elise, and thank you very much, Elaine, for a really good introduction to the background of that enigmatic business of cancer of unknown primary and malignancy of undefined origin with a backdrop of acute oncology. Next slide, please. So before I go any further, actually, I would like to revisit the challenges that we face as a group of healthcare professionals in acute oncology dealing with cancer of unknown primary patients, but not just from our perspective, also from perspective of patients and the carers as they go through this journey. We are dealing with poor survival outcomes, as Elaine indicated, that this is a poor prognostic group. A median overall survival is actually between 4 to 12 months. There are issues around the patient pathway itself. There's a lot of anxiety, uncertainty about the diagnosis in itself. The patients are quite symptomatic, and that leads to a poor quality of life. And also these patients mostly have a delayed oncology or specialist palliative team input. And additionally, you probably have realized in primary care that we do not have a robust pathway in place for referring on these patients to the appropriate teams. These patients do not have a dedicated key worker as we speak in South Wales, and that does not give them any continuity of care. So they eventually end up having multiple investigations, prolonged length of stay, readmissions, and gets virtually discussed in several MDTs, often with futile outcomes. And they do have a late or no recruitment in clinical trials and clinical studies. This is indeed an uphill task for all. Next slide, please. So with that background in mind, NICE guidelines from 2010 and NHS England peer review measures from 2014 did offer us a structured framework for managing these patients in a holistic manner. So the recommendations went like this, that every cancer center or unit or even network should have a dedicated cancer of unknown primary team. The membership of the team consists of an oncologist, a palliative care physician, a CUP specialist key worker, and as well as consultant radiologists and consultant pathologists as core members. Post-referral to the MDT, for inpatients, the expectation is they're going to be reviewed either by the acute oncology team or the CUP team within 24 to 48 hours, while for outpatients, recommendation is they should be assessed in outpatient clinic within a 2-week turnaround time. And also strong recommendation is these patients should be discussed in CUP dedicated MDT. Next slide, please. So over the last few years, I've spent a lot of time and effort invested in development of acute oncology as a specialty, especially cancer of unknown primary. And I've come across a fair few myths centered around cancer of unknown primary patients and their pathways. And amongst that list, the top 2 myths are namely as below there on the slide, as you can see. The first one is that CUP is a rare cancer. This is something that many people, including healthcare professionals, would still believe, but actually in the United Kingdom alone, approximately 24 patients are diagnosed with CUP every day. The annual caseload is 10,000 and counting, and it's actually more common than many other cancers that we are more familiar with, like sarcoma, lymphoma, small bowel cancer, anal cancer. And there is a national thought that even the numbers that we see on the database may be unaccounted or underrepresented because of the uncertainty of the diagnosis and coding. It is the 4th commonest cause of cancer death globally, and that should say something on the impact of overall cancer services. And the second myth is that the CUP patients have a poor prognosis. So do they even need an early and oncology specialist input? And to answer that query, NICE has basically laid down strong recommendations on early oncology input for all these patients. Now, if you look at the whole group, and I'm going to talk about this in greater detail down the presentation, there are two distinct subgroups. It is actually a diverse cohort of patients, but two distinct subgroups. The first subgroup is the favorable ones with good outcomes if they can be signposted for appropriate investigations and appropriate management at the right time by the right specialists. The second group is the not so favorable group with poor prognostic features, and early oncology input is strongly recommended in this group for taking a call on cessation of tests and invasive investigations and early signposting to palliative team, thus enhancing patient experience and patient journey and quality of life. Next, please. So now I'm going to talk about data analysis from a cohort of patients of CUP-MEO over calendar year of 2018, and this is from Southeast Wales. Why 2018? It's really a random calendar year. And the reason is that it was literally before we started thinking of having a dedicated CUP-MEO patients, but the important thing is that it is very much representative of the whole patient population in terms of demographics, patient outcomes, journeys, and maps well to nationally published databases. Next, please. So in calendar year of 2018, Canis coded 235 patients in total across the 3 health boards. But if you can see on the box there on the right, when we looked at the data from acute oncology databases for each of these health boards compiled together, the number was 143. So clearly there's a discrepancy between the two numbers, and that is probably accounted for by the challenges of Canis and the way things are coded, and lack of awareness at MDTs when these patients are getting discussed and rediscussed. So if you look on the top left there, we have mapped out the referral pathway for these patients. Significant proportion of these patients came from medical and surgical specialties, not surprisingly. And then you can actually see what is the surprising part is, and the interesting part is the one that pops out in orange there. So those are the patients, a significant proportion came straight from primary care via GP referrals. And then if you look on the top right, that is a typical age distribution and gender distribution of this cohort, with median age being 70 to 75 years and a slightly more preponderance for the male gender. If you look at the bottom right, you can see we are mapping out the fitness for these patients, a fitness assessment, performance scoring, as Elaine referred to in her presentation. And while a significant proportion were fairly fit for further investigations and treatment, as typical of this group, quite a few were not really appropriate for further investigations, were clearly very symptomatic from the disease burden. And the interesting part was a significant proportion did not have any documented performance scoring, which actually has a big impact on the further patient management and the journeys. Next, please. So then if we are looking at the left pie chart, we are talking about tumor profile, and so about 40% of these patients eventually stayed as malignancy of undefined origin or cancer of unknown primary without any further tissue diagnosis because they were clearly unfit for any further invasive tests. But a significant proportion, at least more than 1/3, actually were identified with either occult or obvious tumor sites. And then the rest of the population were distributed between confirmed carcinoma of unknown primary or non-epithelial lineage, hematological malignancy, or others like germ cell tumor, sarcoma, etc. Some of them were even benign. Now, if you look at the top right, 1/3 of these patients ended up having active anti-cancer treatment, whereas 2/3 did not. If you look at the bottom right now, For the ones who received treatment, that pie chart is only dedicated to the ones who underwent treatment. And we can see that a significant proportion had palliative radiotherapy as their main modality of treatment. But then again, there will be quite a few patients in the whole group who received multimodality of treatment and some who received only systemic therapies. Next, please. And then we are looking at the palliative team input, MDT input, and survival for these patients. If you look at the first bar chart, it shows that 50% of the patients had documented palliative team input, whereas 50% did not. The second bar chart shows that 40% of the patients did not have any documented MDT discussions. And the final bar chart shows that a significant proportion, the majority of the patients have passed on from the time of diagnosis to data analysis, but interestingly, at least 13 are still alive and well. That is actually it drives home the point that there is going to be a significant proportion out of the favorable subgroup who will do well on treatment if they can be identified early on. Next, please. Then just going into a further deep dive of survival for the whole group as such. On the left here, we can see survival curves or what we call Kaplan-Meier curves for the non-oncology groups. It's probably not something that you're familiar with. So essentially, we're just trying to map the survival for these patients. It's mostly in terms of months, and that is typical of the poor prognostic group. But if you look at the right now, so this is a breakdown of overall survival for the patients who were on treatment, active anti-cancer treatment, that is the bar, that is the graph in green, as versus the patients who did not receive any active anti-cancer treatment, and that is the graph in blue. And you can see a clear separation of the two curves, which basically indicates the patients who went on active anti-cancer treatment did far better than the persons who did not get any treatment. Now, having said that, this does not indicate or support the fact that the whole group should be offered treatment. Far from it. It is a poor prognostic group. I think the emphasis and the message coming out from the graphs is that we should put in every intent and expertise in trying to identify the two groups early on and separate essentially the wheat from the chaff for the favorable outcome, signpost very quickly to the appropriate specialty groups or appropriate management, whereas for the unfavorable group, signpost them early on for best supportive care and cessation of investigations. Next, please. So in conclusion, from the data analysis alone, in 2018, CANIS coded for 235 patients, but acute oncology database showed 143 patients in total. Having said that, because of the challenges in coding and CANIS, we think these figures are overall underrepresenting the disease population. Majority of the patients, 93% in fact, received acute oncology input within 24 to 48 hours. So that's great achievement because we have actually ticked the box on national recommendations there. 37% of the patients, almost 40% of the patients were diagnosed with MUO, and they were too unwell for further treatment. And this is aligned with a nationally published database. 1/3 of the patients received oncology treatment, and this group, in fact, had a highly significant survival advantage. But 50% of the patients did not have any documented MDT input. The ones who had MDT input had multiple discussions, and 40% did not have any documented palliative team input. So there's gaps there that we can try and address in future. Next, please. So can I just jump into a real life scenario from 2019, just to give us a reality check on the patient pathway here. Next, please. So this is an unfortunate 90-year-old lady who presented initially to GP surgery with anemia in the summer of 2019. The symptoms were vague. She gradually had progressive symptoms, which warranted further investigation, and credit goes to the GP surgery for arranging all relevant tests, including an abdomen CT, abdomen pelvis CT, as well as a comprehensive battery of tumor markers. Unfortunately, as is typical with these MUO cup patients, the tumor markers came back as random, completely all over the place, and inconclusive. Abdomen pelvis showed diffuse peritoneal metastasis, and as Elise referred to, typically did not show any obvious radiological evidence of primary. And then it made it more difficult to signpost her to a specific urgent cancer pathway. So a primary care called Velindre for some advice. Velindre oncologists advise for the patient to get admitted under the medical team via ED or AMU for comprehensive workup, including a tissue diagnosis, as well as signposting to specialist teams early on in the pathway. In parallel, oncology team also emailed the in-house acute oncology team in the LHV so that they had a heads up on this lady's arrival and could plan accordingly. But unfortunately, the best laid plans of men and mice, it fell through because that was a very busy night in ED. And I remember it was a Friday night. The on-call team actually turned this lady away, saying she did not fit the criteria for acute admission. She went back in the community and then underwent several investigations, multiple virtual MDT discussions, and several different SST MDTs. Palliative team actually came into the pathway fairly late on. She ended up having a laparoscopic biopsy, suffered from complications, came back to ED, and died in ED. So we are talking about 5 months of gap between the point of suspicion to her final demise. Next, please. As we speak, local health boards are forming a collaboration group with acute oncology team and Velindre Cancer Center clinical leadership collaborative group, looking at how to redesign and improve on acute oncology, unscheduled care pathways, and cancer of unknown primary service has a very clear remit in it. So we are looking at a new service for these patients, hopefully to be instituted this year. If we are talking about a new CUP service, which is going to be aligned very well with the national recommendations of NHSE and NICE, how is that going to impact on the overall flow of such a fractured pathway? And let's just relook the pathway again. If you look at the drop-down bar, which is intersecting the timeline fairly early on, you can see where we can come in. When the GP surgery would have diagnosed this poor lady with a cancer of unknown primary on the scans alone, they could have signposted this lady fast-tracked to CUP service either directly through the MDT or indirectly through acute oncology team, which would have facilitated early oncology input, fitness assessment, addressing patient concerns and anxieties, and arranging for appropriate investigation or even cessation of inappropriate investigations, building on quality and quantity of the patient pathway. Next, please. So then we are coming to the final slide here to throw a little bit more light into the CUP MUO referral pathway for the new service. And this has been peer reviewed by LHV acute oncology members across Southeast Wales. So essentially, we are looking at portals of referral coming from medical surgical specialties, local health board acute oncology team, site-specific MDTs, palliative team, all directly via e-referral to the CUP key worker. And you can see very much so primary care and RDC would be part of the program too. I have left it as a hashed line rather than a solid line, and that is because we may have to look at this separately because the funding stream might be different from the rest of the acute oncology funding stream coming from LHV. So essentially, we are looking at discussing these patients either at daily acute oncology MDTs or weekly CUP MDTs, or maybe a combination approach for suitable patients, with the provision that suitable patients are going to be assessed early on in a CUP-specific clinic or an ambulatory oncology clinic within a turnaround time of 2 weeks. And if the end patients are going to be reviewed by the in-house acute oncology team with support from the CUP team. And then that facilitates early signposting and referral to the right specialty at the right time. If it's solid tumors and if it's confirmed carcinoma of unknown primary, they are retained in the CUP clinic and they can get signposted and recruited to clinical trials and studies as appropriate. For the patients who are clearly unfit for further investigations, we stop investigations proactively and signpost for best supportive care. And for the ones with occult primary identified, we fast track them to the site-specific groups. For the non-epithelial hematological malignancy or even the benign pathologies, we refer them to the appropriate specialty without any waste of time. This, so if you look at the referral pathway, we do envisage that we're going to have very strong links with palliative team, not just the in-house team, but also the teams in the community, as well as in the local health boards, and also strong links with palliative radiotherapy clinic, as Mick Button shall be touching on that shortly after the presentation. Next, please. So I would like to thank all my team members and persons who have supported me in this vision of a new CUP service for Southeast Wales. That's acute oncology team from the LHBs, Cancer Network Wales, Clinical Cancer Need from my own cancer center, and Welindra Canis team, Wales Health Collaborative data managers, as well as, of course, the in-house acute oncology team. Thank you very much, and I'll be happy to take questions.
Thanks ever so much, Sonali. You've covered an awful lot of detail and I'm really grateful for that. I'm aware that it may have been quite quick and there's a lot of detail within those slides. So obviously people can get the link from Charlotte afterwards and follow it on YouTube if people do need to just slow it down and just focus on any of those slides. So that'd be great. I think the other point that I think I'm going to resonate from primary care in that is when we do get those scan results back, if there is a development of the CUP service, that radiology refer into the MDT there as well at the point of diagnosis, which I hope will be part of the pathway, but I know we can pick up on that you know, in the future. So without further delay, a lot of you may well know Dr. Heather Wilkes, who's one of fantastic GPs down in Neath Port Talbot, who has been fundamental and a real forerunner of the development of rapid diagnosis centres in Wales. Heather, if the builders aren't in your room at the moment, can you join us?
Yes, yeah, it's all good. So any screech noises, it's not me. I'll try to be brief. So yeah, I'm Heather Wilkes. I'm a GP in Britain Ferry in Neath, clinical lead for the RDC in Swansea Bay and for the national rollout across Wales. Next slide, please. I'd like to tell you a bit about the rapid diagnosis centres and explaining what they are. They're a dedicated clinic that primary care can refer patients to in with worrying symptoms. These are symptoms that could be due to a cancer, but there are no site-specific red flags to allow a referral on the usual USC pathways. And in Wales, we're still of one of the countries, the very few countries where USC referrals can be downgraded if it's felt not to meet the site-specific requirements. But as we know, GPs have gut instinct that there's something wrong. We don't know what it is, but we know there's definitely something going on. And the RDC's aims to improve patient experience and patient outcome by promptly investigating these patients and having excellent pathways of communication across the board, and also improving primary secondary care working. What we're there for is to try and get to the bottom of the patient's problem as soon as possible and sort it out together. Next. So what do I mean by vague, non-specific symptoms? I think most of us who work within primary care understand that it's unexplained. So you may do a blood test and the findings, you get a thrombocytopenia, hypercalcemia, and anemia, often non-iron deficient, unexplained weight loss with no other site-specific signs, severe fatigue, appetite loss, nausea, and this atypical pain. And there are a lot of these patients out there, and health boards now, it has been proven, we do need to have a pathway for these patients. GP gut instinct studies have been done, and it shows a nearly 30% prognostic indicator of something serious going on. We just don't know where to start. Next. So when somebody comes in to the GP surgery and have an as yet undiagnosed cancer, 50% will come in reporting the traditional red flags, the blood in their wee, in their poo, coughing up blood, a lump in the breast. But 50% with cancer will come in complaining of the vague, non-specific, quite common symptoms, and it's how we know that that's due to something that's common and not important, not serious, but there is something, you may have a serious disorder and it may be cancer, and that's what the RDCs are there to try and sort out. Next. So what is it about an RDC? It is a unique, it's improving and increasing in numbers, but it's quite a unique clinic. The one that I'm involved with within Swansea Bay, it's a primary care resource in a secondary care setting. It's a diagnostic centre for primary care. We can refer in patients who don't fit traditional cancer pathways. The patients, when they're there, they have generally a CT tap, which is reported live by the radiologist. The patients that are seen on the day are discussed before clinic with the radiologist, the CNS, and the physician in the clinic. The patients then have their CT tap and their appointment with the consultant. Then the consultant or GP, I do the clinic sometimes, and we have other GPs that work alongside us, and the radiologist discuss the clinical findings along with the radiological findings, also correlating that with any other information that's in the system on the patient, GP letter, any other secondary care contacts, and then a plan is made. A decision on diagnosis, onward referral, further investigations is made there and then the patient and their family are informed and then totally involved in what happens next. CNS is in the clinic, who provides excellent support to the people working in the clinic, but more importantly to the patients and the family. They're the point of contact for booking the appointment, they're a point of contact when they're in the clinic, and also key worker if significant diagnoses are made, and onward support. This is totally person-centred care. The patients and their families are involved in the decision making at every point. And this isn't a yes, no, this isn't you've got a pain or this pain is not my area. It's so much more than a yes, no clinic. And often we provide rapid reassurance for patients, families, carers, and for GPs, because a lot of the time we can reassure people that there is nothing sinister going on. Next. So what happens? So the GP sees a patient and you think, oh, there's something going on. I don't know where it is. And so you decide to make a referral to our RDC. It's done electronically via WCCG. We need to be sure that they're not suitable for any USC pathway, that they're vague symptoms that could be due to cancer. At present, the RDC is to look for occult malignancy. You could argue there's a need for a vague symptom pathway in general, but that's a much wider diagnostic area. This is for potential malignancy, and at the moment it's adults, and that the patient is well enough to attend and to go through the process. What we ask is that a set of bloods are done in advance, and they're on the slide there. You don't need to wait for the results, they just need to be available for MDT. Dip the urine in case of a renal malignancy. Record a full physical examination and a weight, so patients do need to be seen and examined and weighed, and explain to the patient what's happening, that you do think that there may be something serious going on and you'd like to get to the bottom as soon as possible. Thank you. Next. Sorry, the drilling has started. We opened in June 2017, and results up into the November are on the slide here. We've seen 1,329 patients. The average age has come down to 67 years. slightly more females than males, and we've had nearly, well, by November, 317 clinics, and the age range is 19 to 95. Next. So what have we picked up? I think it won't be any surprise to see the list that we've picked up, those more difficult to suspect. In particular, lung cancer. We all know a normal chest x-ray doesn't exclude a lung cancer. Renal cancers, MUOs, very common, as Sonali said in her previous talk. Pancreatic, colorectal, either because the patients were too young for the USC pathways, or because they didn't have any melena, and the list goes on, including some quite very uncommon ones. When we look at referrals into the clinic, our cancer rate, pickup rate, is just below 11%. Next. But we also pick up significant non-malignant diagnosis. Another 35% of the patients in the clinic have a significant non-malignant diagnosis. And these then can often be life-changing and can be fatal. And again, this is for patients where the GP suspect there's something wrong, but there isn't any definitive areas that they can refer on. So as you can see, again, a wide range of patients. Next. So when we look at, sorry, it's a bit of a busy slide, but it's based, the big one in the middle is weight loss on its own. The blue are those with no diagnosis found for the symptoms, and the orange is a cancer diagnosis. So this takes out the non-malignant diagnoses. And the majority of people come with weight loss associated with other findings, the main one being loss of appetite, anemia, abnormal lab findings, and atypical pain. Next, 50% of patients are sent back to the GP, either because no diagnosis was found and it was felt that there was no sinister pathology going on, or a diagnosis that primary care could manage was found. Looking at this, the one on the left, cancer diagnosis, that's just a pie chart of the symptoms that these patients reported on referral. The one on the right is the patients where no diagnosis was found and they were felt to have no sinister pathology, and that was their symptoms. So as you can see, as a GP, it's virtually impossible to separate the two. This was done as a pilot, and we're still reviewing the data, but we looked at those patients who had no cause for symptoms found, discharged back to GP. We looked at them a year on. We had a very good response rate from GPs, and no significant diagnosis was found 1 year on. Next. We did an economic evaluation with the Swansea Centre of Health Economics. And when we looked at the patients who came to the RDC and received a cancer diagnosis, we were found to be very cost effective. Next. Sorry, if we can go back one, I thought I had another slide there. So when we looked at those, as opposed to the patients who were referred on a USC pathway, were downgraded, but then found to have a cancer at the end of it. The patients in the RDC, which are those very patients, had a cancer diagnosis in less than 6 days. Those that were downgraded and referred, it took 3 to 4 months. The average cost of the patient with a cancer diagnosis in the RDC was £500. The average cost of the downgraded USC cancer patient just to diagnosis at 4 months was £2,000. So we were far quicker and actually cheaper, less resources, which we all know patients bounce around the systems, unfortunately. Next and final slide, I think. So the RDC, it's not for all vague symptoms, it's where the GP suspects there's a malignancy. It's not just rapid access to CT. As a GP, we just don't want to know that the CT is normal. That isn't the whole answer. And as yet, it's not for site-specific symptoms, but this is a pathway of patient investigation that I think should be rolled out. So it is for vague symptoms with a potential malignancy. You are there to trust the GP and value the gut instinct. There is a referral vetting system, and we need a joint dialogue, and I believe every health board in Wales should have one. Thank you.
Thanks ever so much, Heather. You've been such a powerful force for change with that in Swansea Bay, and I know there's also one up and running in Cwmtath, but there's also plans afoot for most health boards in Wales at the moment, aren't there, which is great, and we'd all benefit from one, clearly, by the data you've presented. Time is tight. Mick would like to do an update on palliative radiotherapy. So this is Dr. Mick Button. He's one of the consultant oncologists in Velindre. Mick.
Thanks, Elise, and thanks everybody else. A really good session. I've enjoyed listening to all the presentations. Lots of areas where there's opportunity, I think, to improve patient care and experience, particularly as a lot of the presenters said there's not easy pathways for these patients. So I want to talk a little bit about palliative radiotherapy. Okay, the next slide, please, Charlotte. Thank you. Related to this subject, it's a very useful treatment for patients with advanced cancer. It's used a lot in patients with carcinoma of unknown primary or advanced malignancy. It is a bit of a dark art sometimes. You may have seen radiotherapy as a medical student or rotating through your training schemes or something like that, but it's something that kind of happens in the background sometimes. So I want to talk a little bit about the practical aspects to try and improve patient care and experience. I suspect everybody on this will have some patients who have radiotherapy at some point, and they'll be scared and they'll be worried. So better knowledge might help allay those anxieties, help better teamwork and ultimately better patient care. So we do need to be a bit careful with radiotherapy. It can cause some side effects, so decision-making needs to be careful. It's not always helpful, and it does have its limitations. I'm always very clear with my patients that palliative radiotherapy is about quality of life and often doesn't give a prognostic benefit, but it can improve what time someone does have left. With the caveat that if we're dealing with an emergency situation like bleeding or superior vena cava obstruction or cord compression, radiotherapy can have a prognostic benefit through controlling someone's cancer. But despite those limitations, it's a simple treatment, it's often well tolerated and effective, and can usually be done as a short course as an outpatient. There's some links there for some videos which we've done and other cancer centres which just talk through the practical aspects of radiotherapy, which can be helpful for patients or healthcare professionals. Next slide, please. So what's it good for? It can help things like pain primarily, which can either be from the primary tumour or spread to other parts of the body, typically bone metastases or subcutaneous metastases, lymph nodes which are painful. It's quite effective at bleeding, from helping control bleeding from tumours in all sorts of parts of the body, and helping relieve pressure symptoms like lymph nodes pressing on things, superior vena cava obstruction or bronchial obstruction. It can sometimes be helpful for brain metastases, but comes with some more side effects when you're treating someone's brain, so we need to be careful there. And it's used a lot as an emergency situation, typically for spinal cord compression. Now, we can use palliative radiotherapy without a tissue diagnosis, so those patients with advanced cancer who are not very well but symptomatic, we do need to be careful with that though, to make sure we're not missing out on one of those diagnoses that might be more treatable, such as a lymphoma or possibly even something like a germ cell tumour or a small cell lung cancer, where we can dramatically change prognosis through further treatment. Next slide, please, Charlotte. So just a practical case here, a relatively young patient of mine, non-smoker, history of right hip pain affecting her walking and ability to look after her children. She had various scans and ended up being sent to Birmingham and was found to have a lytic metastasis in the inferior pubic ramus. Charlotte, next slide. Otherwise fit and well. We felt it was important to get a tissue diagnosis here, someone who's 45, good performance status. We are looking at systemic therapy, so we did get a biopsy which showed metastatic lung cancer. Next slide, please, Charlotte. And she attended for just a single fraction of radiotherapy. You can see the beams there that we plan, a little bit of shielding to exclude the bowel and the bladder to reduce side effects. And she came back to clinic very recently and she was walking without crutches. She was able to look after her kids better. She's still got pain. The palliative care team were involved. We've looked at analgesia and she had steroids with her radiotherapy, but a very simple, effective single treatment to help her symptoms and improve her quality of life. And now we're looking at systemic therapy to come in afterwards. Next slide, please. Other areas, slightly more widespread bone metastases on the left there. Sometimes you need to be careful in terms of your field of how big or how small you have to be. And on the right, a patient with a collapsed vertebra causing spinal cord compression. Next slide. And again, just a simple beam we've put on the back of that with either 1 or 5 treatments, often as an inpatient for spinal cord compression. In terms of practicalities, I get asked a lot of questions because patients come to clinic quite worried and they don't know much about it. So it is usually done as an outpatient. We can do it as an inpatient, depending on geography and fitness and how many doses we're using. We do, go through a consent process and decision-making with the patient. If radiotherapy is appropriate, they'll come to the cancer centre for a planning scan, which is a CT scan. It'll take about 15 or 20 minutes. They will have tattoos, which are not necessarily in the area we're going to treat. We put them in a reproducible place like the sternum or the pelvic bones, and that causes some worry for patients. And then usually a few days later, after they've had the treatment plans, they'll attend for their treatment. We may use supportive medications like anti-sickness medicines or pain relief, but it's not like an operation where they need to be nil by mouth or anything, and they're not radioactive afterwards. In emergency situations, we can treat the same day, 7 days a week. Urgent patients we can see very quickly, and I'll talk a little bit about the rapid access palliative radiotherapy clinic. Or for more complex things, it might take a week or two to do a more complicated plan if we're pushing the dose up a bit. Next slide, please. Downsides, travel can be difficult, especially if patients are unwell or in pain. The couches for planning are really hard. There are short-term side effects, very much dependent on which part of the body we treat. So in the top right, we've got a kidney cancer causing hematuria. Patient having radiotherapy there might get some nausea or diarrhea. And the bottom, we've got a tumor on the right causing SVCO, and someone having radiotherapy to the lung might get a bit of dysphagia because the esophagus is treated, or possibly some pneumonitis, and maybe a little bit of skin inflammation. Radiotherapy is not always effective. For things like spinal cord compression, it tends to stabilize neurology rather than improving it, and that's why early treatment is important before the neurology develops and worsens. And it can take some time to have its beneficial effect, which is why the other supportive medications alongside it are very helpful and important. There is a limit to how much we can give. The bigger the volume and the bigger the dose, the more the side effects, and we do need to be careful. We can often retreat, but there is a limit to what we can do. I'm not going to go into that because that will take me hours to go through. Charlotte, next slide. Some areas where it's not so useful. If a patient's very close to the end of their life, probably the burden is greater than the benefits. If they've got really uncontrolled symptoms, just the physical act of traveling to the cancer center would be difficult. If they can't lie flat, it can be difficult, although sometimes we do have ways around that. And things like a risk of a pathological fracture, so there's a lytic metastasis here in the femur. A surgery should be considered in patients like that. And we do think of other treatments that may be embolization for bleeding, stenting for SVCO, and sometimes even surgery or chemotherapy if someone's got a chemosensitive cancer. Next slide. So it is very useful alongside other measures to manage patient symptoms. It's not given on its own. It's part of a palliative care package. Can help a wide variety of problems, but does come with side effects and a burden, and it's not always helpful or appropriate. But on balance, it's often simple, well tolerated and effective. And we want to make it easier to access radiotherapy. So we've set up a palliative radiotherapy clinic, a bit like the Rapid Diagnostic Center. So patients can be referred in and reviewed for consideration of palliative radiotherapy. And the model of being seen in a rapid diagnostic center and then referred rapidly through to your cancer center would be a very quick pathway. And thanks very much to the Bevan Commission who've supported that development. And we're linking in with cancer centres across Wales to see if we can make that service available more broadly. Thank you.
Thanks very much, Mick. And time-wise, we're right on it now, so we've only got a couple of minutes left. I think the couple of things I just wanted to highlight, tattoos you referenced, they're not big, you know, Cardiff bluebirds or anything, are they? They're little tiny blue dots for those who haven't seen them. And I think just, you know, when we've done these face-to-face and we've had the radiotherapists come and talk, you know, the sort of the hardboard, the masks sometimes they need to use for stabilisation are important in terms of the suitability of patients, which I think was really useful that you highlighted towards the end. There's been a couple of questions on the chat which we've been able to answer, but I think unless any of the speakers wanted to come back in on anything that they felt they wanted to comment on, I think we'll aim to bring it to a close now. Please, can you fill in the feedback and help us direct what the next sessions should look like with the hope to remodel similar things in the future. We're getting about a quarter of you filling in the feedback forms, and just to keep these free and ongoing, we do really need as much feedback as we can possibly get. The survey will be open for a week from here. Many thanks to Charlotte and the team for supporting this, and to all the speakers. Mick, Heather, Sonali and Elaine. The question I can just see in the panel about rapid diagnosis centres opening in all of Wales, particularly Cardiff. Heather, did you want to come in on that? Do you know a bit more? There's a RDC working group been set up, certainly, and some of the plans are more advanced than others. Heather, do you want to give any more detail?
Yeah, we've got a support. We've got project managers, myself as clinical lead, to all health boards in Wales. It's only been sort of going this last sort of few months. And Iron Bevan actually did open theirs last year, and different health boards are in different stage of development, but I am in discussions with all health boards. So if you want to rally your own health board and tell them how much you as a GP or whatever profession you're in, you feel that you need it, then that will help. But I am in discussions with all health boards, so hopefully there'll be one near you soon.
And Heather was part of the original Macmillan Framework for Cancer as a Swansea lead, so all the Macmillan GP leads for each health board are very much involved as well. Does the 2-week rule apply to these centres? I mean, if they fit a 2-week USC pathway, they should be on that, shouldn't they? And as Heather was saying, mostly they're seen within a week, aren't they, your RDCs?
Yes, we start to look at extra slots if we have more than an 8-day wait. All of our patients, we keep below 7 days. Generally, if it goes up to 8 days from GP referral, and GP can refer at the point of suspicion, which often is the very first time they walk in. The blood test can be done or on the system within 24 hours the next day. So that is the point. It is speed. And, you know, as Mick was saying, if somebody's got a cord compression, which we've had, along with lots of other imminently fatal or disabling conditions, they are seen and treated within a few days. So no, the 2-week wait would be far too long for us. Sorry, and if possible, I'd like to thank the Macmillan Framework for Primary Care and Cancer Network that was been on this journey with me.
Thanks ever so much, Heather. So we'll close now. Thank you for attending. And there is one more session next week. Fiona's leading that one on how to have difficult conversations and communication skills, tricks of the trade, and a bit of a roundtable discussion with some of our AOS colleagues as well, Acute Oncology Service. Many thanks and see you soon. Bye-bye.
Thanks, everyone. Bye.